Hello, future nurses. This is Professor Flourish. Today, we're going to be talking about the management of patients with structural, infectious, and inflammatory cardiac disorders. So the first thing we're going to talk about is our valve disorders. So these are our tricuspid, mitral, and aortic, and then our arterial ventricular versus semilunar. So your valve heart disease describes an abnormality or dysfunction of any of the heart's four valves. So on the left side, we've got our, can't really see it on here, but it says our mitral valve on the side there. And then we've got on the, in the aortic valves on the left side. On the right side, we've got our tricuspid and pulmonary valves. Tricuspid valve dysfunctions occurs secondary to usually endocarditis or IV illicit drug use and is very rare. And if you think about it, it's because it's located on that right side of the heart. So you don't really putting as much damage on it unless you're putting something infectious through that line and having it go back through. Your valve dysfunctions can affect the efficiency of the heart as the pump and reduces that stroke volume. Over time, there might be a remodeling of the heart itself, so it causes that hypertrophy and heart failure. So that's what we get really concerned with these valve disorders, is that it causes that remodeling of the heart. With aging, you get that thickening, which occurs in both the mitral and aortic valves. The aortic valve is stiffer in older adults, which increases that systolic blood pressure and stress on the mitral valves. So just like as a summary, aging causes that thickening of the mitral and aortic valves, which causes increased systolic blood pressure and stress. So that's why for the most part, what you'll see is with your disorders, unless it's an IV drug user, for the most part, you'll see more of the mitral or aortic issues. So your disorders can come in different varieties. We've got regurgitation, which is the valve does not close properly and blood backflows through the valve. So regurgitation is just that, it's that backflow. Stenosis is that narrowing, so the valve does not open completely and the blood flow through the valve is reduced. Valve prolapse is the stretching of an arterial ventricular valve leaflet into the atrium during dystole. Now, your valve heart disorders can be congenital or acquired. So congenital valve heart diseases can affect all four valves, and it can be either stenosis or insufficiency. Acquired means that it's over time, and it can be classified as three different types. So the acquired ones can be your degenerative, so that's due to age. So you've put a lot of stress on it, like arteriosclerosis, hypertension, and that's the most common in your developed countries. Then you can get your rheumatic, which is that calcification of the valve cusps, and most common as well in countries. And then you've got infective endocarditis, which is just those organisms destroying the valve. So, like I said before, with our valve disorders, we've got congenital, which means I was born with it. Then we've got acquired, something in my life caused me to get it. And then within your acquired, you've got three different types, which is degenerative, which is over time I developed this problem, rheumatic, which is I got some sort of strep when I was younger, didn't take care of it, and now I've got this rheumatic heart disease, and infective, which means that something like I did IV drug use, and now my valves have all this bacteria growing in them. This is just a picture of how the heart actually flows the blood where everything goes into it. So the right side of our heart collects oxygen, poor blood from the body and pumps it into the lungs. The left side of our heart collects oxygen-rich blood from the lungs and pumps it into the body. This right versus left will become very helpful to kind of understand these two differences when we get into our heart failure lecture. So one of the first ones we're going to talk about is mitral valve prolapse, mitral valve regurgitation, and mitral stenosis. So on the side here, we've got an example of that prolapse here. So prolapse is a condition in which the valve flaps of the mitral valve does not close smoothly. Instead, it tends to bulge or prolapse upward into the left atrium during contraction. So when we try to contract, instead of it kind of having that close, it's pushing upwards. This is a video, you can find it on Momentum. It kind of goes through mitral valve prolapse and regurgitation. Okay, so with this, like I was said, mitral valve prolapse, you're going to hear that mid-systolic click with that one, and it has that ballooning of the valve leaflets. It can typically be without symptoms. It's more common in women and may be caused by connective tissue diseases, resulting in that enlarged valve leaflets. But a lot of times it often remains just unknown. 15% have progressed and developed hypertrophy, AFib, or pulmonary hypertension. So with mitral regurgitation, remember regurgitation is that backflow. They usually hear a systolic murmur, so that blowing sound. It can be chronic or acute. The pathophysiology is basically the left ventricle contracts, causing blood to flow back into the left atrium. So that's what happens, is instead of it flowing out through the rest of the body, it's backing up into the left atrium. This blood is added to the flow from the lungs. The left atrium stretches and dilates. The blood backs up, causes pulmonary congestion. The right ventricle is strained. Blood volume becomes so high in the left atrium that it causes blood not to expel from the left ventricle, and the left ventricle hypertrophs. So then you get that left ventricular hypertrophy, which causes systolic heart failure. So that's where the real problem is that these left ventricles contract and causing the blood to backflow into the left atrium. So we're not getting a good blood flow with it. And then you're developing that heart failure. So some of your symptoms and treatment of mitral regurgitation. So symptoms warrant medications or procedures. So some of your symptoms can be symptoms of heart failure. They may develop dyspnea on exertion. So that's the thing with that mitral valve stenosis or the mitral valve regurgitation. You just kind of want to watch them for that dyspnea on exertion. Less common are shortness of breath, polyps, cough, and then progression is if it's increasing exertion and the less common symptoms. Usually they use medications for heart failure, which include afterload reduction. So if we're thinking about our main goal being afterload reduction, why do we think that is? And I'll give you a second to think about this. So afterload reduction is going to decrease impedance to left ventricular ejection, and as a result, reduce regurgitation volume. So if we reduce that afterload, then we might have less of that regurgitation. So some of these medications are going to be things like our ACE inhibitors, hydralazine, our angiotensin receptor blockers, and beta blockers. So thinking about ways that you might hold an ACE inhibitor. So you might hold an ACE inhibitor if there's blood pressure concerns, watching for that increased risk of hyperkalemia, because these patients watch for anything like this potassium-sparing diuretics. You just kind of want to make sure that you're watching your patients for blood pressure and their electrolytes. So for your stenosis, this is a stenotic or stiff valve, most commonly caused by rheumatic endocarditis, infective or rheumatic. Obstructs blood from the left atrium to the left ventricle. So now we're going from the atrium to the ventricle. So instead of having that pushback, it's that it's closing and it's getting smaller. You'll hear a diastolic murmur with this one. Typically, the valve is 3-finger widths wide and can narrow down to the size of a pencil top width, and this increases resistance. So the pathophysiology for it is you'll have poor left ventricular filling, which leads to decreased cardiac output, which leads to increased left ventricular volume, which leads to hypertrophy, which leads to pulmonary vein congestion. Pulmonary congestion leads to right ventricular contractions against high pulmonary pressures and increased right ventricular strain. Right ventricular hypertrophy causes increased heart rate, decreased cardiac output, and increased pulmonary pressure, which all leads to dyspnea on exertion and pulmonary hypertension. So basically, we're getting this dyspnea on exertion, we're getting this pulmonary hypertension, all because of these things kind of leading into it closing off. So yeah, like I said, that's just the pathophysiology of what's happening to it. You've got that poor filling, and then you're getting decreased output. So you're increasing the volume going into the atrium because the body is basically trying to fix it because there's not enough blood flowing through the rest of my body. So it's going to try to give me more blood by trying to fill up the atrium. The problem with that is I'm causing my heart muscles to become very enlarged, all leading into this dyspnea on exertion. Some of your symptoms can be in fatigue, decreased exercise tolerance, cough, hemoptysis, so coughing up blood, polyps, orthopnea, proximal nocturnal dyspnea, which basically just means at night I'm having those difficulty breathing and I'm having where I wake up in like a fit of cough. Respiratory infections are often recurrent and arterial dysrhythmias. This here is just like a picture that's very helpful because you are going to want to know the locations to be able to identify. For example, if I've got an aortic area, if I hear a murmur here, which is a systolic murmur, that can indicate that I have aortic stenosis. I've got a flow murmur, so a physiological murmur, or an aortic valve stenosis. So kind of being aware of these different murmurs. With this, also know the age of your patient because with children, this is considered normal. So hearing S3 is considered normal, but in adults, it's considered abnormal. So for this, prevention for mitral stenosis and for aortic regurgitation is focused around preventing rheumatic endocarditis from rheumatic fever. So this is usually caused by streptococcal infection, so strep pharyngitis. So the most effective treatment is penicillin. So it all comes back to that teaching our patients to completely take their antibiotics. So if they do have streptococcal, making sure that they take it so we don't end up developing this later in life. Medical management focuses around reducing risk for arterial thrombus formation with anticoagulants because whenever blood gets together, it can all end up clotting. So we want to make sure that we're watching for any of these thrombuses developing. Treating AFib, consider indications for cardioversion or rate control. And remember what we talked about earlier today. We always start with the least invasive. So if your patient has AFib, the first thing they're going to do is get them on a prescription for some sort of antithrombotic. So they're going to get them on something like warfarin. From there, we're going to try to do these conversion or rate control. So that might be your digoxin, beta blockers, calcium channel blockers. From there, we're going to do the diagnostic TEE, and then we do cardioversion. So cardioversion is the last thing that we would do. So you want them to avoid any strenuous or competitive sports or activity, pregnancy as well. Surgery, they can have valvoplasty, commensuratomy, which basically opens, ruptures a fused valve. They can have the PTCA or valve replacement. So just as a reminder, these are our digoxin toxicities. So signs of these toxicities can be things like fatigue, weakness, your visual changes, so seeing yellow, GI effects. Treatment, stop digoxin and potassium wasting diuretics immediately. Monitor potassium levels, treat dysrhythmias, treat bradycardia. And for excessive toxicity, you can give them the antidote, which is that digoxin immune fab, activated charcoal, clostridium, and these can be used to bind digoxin and prevent absorption. So this is the difference between valvoplasty and commensuriotomy. So commensuriotomy relieves stenosis on leaflets. So that's this one here where it's actually just kind of opening up the leaflets opposed to using a balloon to pop it open. Valvoplasty uses that percutaneous balloon, and the procedure can open up the aortic and mitral valves affected by stenosis. So basically what happens is a catheter is inserted through the femoral artery and advanced into the heart. A balloon is inflated at the stenotic lesion to open the fused commissaries and improve leaflet mobility. So you either kind of slice it open or use that balloon to kind of pop it open. So with your aortic regurgitation or aortic stenosis, you can either have that leaky or stiff valve. So the leaky valve is regurgitation, stenosis is that stiff valve. So it can be caused by inflammatory lesion or dilation of the aorta, rheumatic or infective endocarditis, congenital abnormalities, syphilis, blunt trauma, or surgical deterioration of the valve. The pathophysiology, blood from the aorta backflows into the left ventricle. The left ventricle dilates due to the increased volume. Left ventricular hypertrophy from using above normal force to contract. Increased systolic blood pressure. Arteries compensate with reflex vasodilation. Peripheral arterioles relax, causing a decrease in peripheral resistance and decrease diastolic blood pressure. So all these things kind of lead into one another. And what you'll see with these patients is, first of all, a diastolic murmur, which makes sense because all of this is leading into that decreased diastolic blood pressure, but you'll also see a wide pulse pressure. So pulse pressure is the difference between systolic and diastolic blood pressure. It represents the force the heart generates each time it contracts. So an example of this would be 120/80 yields a pulse pressure of approximately 40. Some of your clinical manifestations, you can have what's called a water hammer pulse, which you'll see marked in the pulsation and the pulse character from forceful beat and increased left ventricular force. This water hammer pulse is just a physical exam describing a pounding forceful pulse with rapid upstroke and descent. So it's just a very strong kind of pulse. Orthopenic and proximal nocturnal dyspnea. So at night, they'll have that attack of severe shortness of breath. Once again, afterload is reduced, and that's what kind of helps it. So we've got our ACE inhibitors, our calcium channel blockers. You want to restrict sodium and avoid volume overload. So if the left ventricular dilation is evident or symptoms are present, they will need an aortic valve replacement. If they don't have any of these symptoms, you don't necessarily have to have the symptoms to warrant the surgery. So if they see that this is a problem, they might go ahead and just replace the valve. So testing includes your TEE, MRI, heart cath, echo every 6 months or 2 to 5 years if no symptoms, or left ventricular dilation. So you got that systolic murmur, which is located in that aortic area. With this one, you're going to have a murmur that's loud, harsh, and radiating. So with it, you can lean forward and exhale to make the assessment clearer and louder. Narrowing of the valve due to calcification and inflammatory changes as a response to the mechanical stress to arteriosclerotic disease. Age, diabetes mellitus, hypercholesterolemia, hypertension, smoking, increased low density lipids are all risk factors. Also, congenital leaflets can contribute, may have 1 to 2 leaflets instead of 3. Rheumatic endocarditis is another theme here. So as you can tell, rheumatic endocarditis has been coming up over and over again. So rheumatic endocarditis can cause these valve problems. So the patho on this is obstructive left ventricular ventricle outflow, increases left ventricular pressure and causes hypertrophy, and clinical signs develop. So the real problem with a lot of these valve disorders is that they're not flowing the blood correctly, so the muscle kind of grows, and when it grows, it causes these other signs to develop. Symptoms can be dyspnea on exertion. So we're seeing a common theme with that dyspnea on exertion. Orthopenia, especially with your stenotic valve disorders, you'll see that dyspnea on exertion. Like I said, orthopenia, proximal nocturnal dyspnea, pulmonary edema, reduced flow to the brain, syncopal episodes, angina from increased O2 demand, blood pressure typical normal to low, pulse pressure is low to reduced blood flow, and you'll have the S4 on exam. So once again, I brought this picture up here just to kind of reinforce where these murmurs are located. So since this is our aortic stenosis, it's located in the aortic area here. And just make sure that you're aware of where that's located. So this is the streptococcal pharyngitis that we were talking about. It's usually characterized by fever, sore throat, tonsil exudates, and tender angiopathy. They can have a cough, nasal drainage, and frank exudates alone are not diagnostic of streptococcal pharyngitis, but just kind of being aware that if somebody gets strep throat, that we're making sure that they're going to see the physician, getting medication for that, preferably penicillin unless they're allergic to it, and clearing this up before it develops into something else. So considerations, you want to treat by preventing prescription factors. So making sure that your patient's taking the medications that they need to if they've got streptococcal. Meds for left ventricular failure, so your dysrhythmias, it's very similar to our heart failures. They may they may get a TAVR, which is a transcatheter aortic valve replacement for valvoplasty. Echo every 6 months for 1 to 5 years. Another thing you want to take in consideration is looking at your ECG. So your ECG with left ventricular hypertrophic changes. So ECG review will show a left ventricular hypertrophy can be diagnosed on the ECG. When the myocardium is hypertrophic, there is a larger mass of myocardium for the electrical activations to pass through. Amplitude of the QRS complex representing ventricular depolarization is increased. And I'll show you guys that on the next slide, what I'm talking about. If valve appears severe, will require sorry. If the valve appears severe, then they will get a left heart cath before to obtain measurements and assessments. So they might just go ahead and do that heart cath, see what it all looks like, and then go from there. VTAC risk is elevated, so avoid exercise stress test. So on here, this is what I was talking about. You can see where that left ventricular hypertrophy is hitting it, and the ST changes here. So with our in our assessment and diagnostics, your echo, we talked about this last week. That's just a diagnostic tool used and will evaluate the for extra heart sounds, specifically a mid-systolic click with MVA. And mitral stenosis will have dyspnea on exertion due to elevated pulmonary venous hypertension, low cardiac output, proximal nocturnal dyspnea. The left atrium enlarges and will place patient at risk for arterial dysrhythmias. So AFib, you may want to consider cardioversion. So with those stenotic ones, definitely watch out for that dyspnea on exertion. Aortic regurgitation, blood flows back into the left ventricle, may be rheumatic, infectious, or trauma, progresses fatigue, dyspnea on exertion, and increased pulses. Aortic stenosis may be asymptomatic, dizziness, syncope, or angina may occur, and you're going to have those loud, harsh systolic murmurs over the aorta. So these are our surgical management that we talked about. We've got our valvoplasty. Repair may be optional instead of replacement to avoid continuous anticoagulant. So we might just repair it so that way we don't have to have them getting a whole new valve. Commissionarotomy places commissionaries between the leaflets, separation of those fused leaflets. The balloon valvoplasty does not require cardiopulmonary bypass, done as a bridge to surgical valve replacement. So a lot of times they'll do this and then they get ready for them to go into valve replacement. So this is our nursing management. For nursing management, you want to monitor your vital signs for any complications such as heart failure symptoms or dysrhythmias, your dizziness, syncope, and education, making sure that they're staying with their medication schedule, your nitro considerations, which we'll talk about more when we get into our myocardial infarction lecture, heart failure, that weight monitoring. So this is the artificial valve insertion. So here you can see where it's a mechanical valve. This is what a healthy tissue looks like. This is what the diseased tissue looks like. You can see how it's completely kind of destroyed through here. And what they essentially do is they take this one and they'll replace it with this artificial valve. So that way it just opens, close for them. They can also use this ring technique as well. And then kind of going back to this valve replacement here. So mechanical valves have an increased risk for thrombus. So this is what's really big about these mechanical valves. The patient will need to take anticoagulants such as warfarin on an ongoing basis. So with these patients, they pretty much have to take anticoagulants for the rest of their life. And the reason for that is because this is a metal implant. So they don't want anything clotting or getting stuck, because these blood clots can form very easily on these artificial replacement valves. So with that, you just want to make sure that they're educated that it's very, very important that they take their anticoagulant therapy, because we just don't want any blood clots forming. So warfarin, since we talked about this yesterday, today, I went ahead and put a, what's it called? The little formula that it is for your INR, which is your international normalized ratio. So it basically tells you how long it takes for blood to clot. So you've got your PT of the patient over the normal reference range. Warfarin antagonizes vitamin K and is reversed to vitamin K. You want to check your PT INR. Normal INR is 1, therapeutic for them, INR is 2 to 3. So with them, you do want to make sure that with your discharge teaching, they know to continuously check their INR. This is just a video about a TAVR and how that's done. So this is our nursing management post-valvoplasty and replacement. So with a valvoplasty, an interventional cardiologist uses a hollow flexible tube or a catheter to insert a balloon into a narrow heart valve. When the balloon is in position, the cardiologist inflates it to widen the valve and increase the blood flow. Other names can be valvoplasty, valvectomy, balloon valvoplasty. So with this, after they've received it, you want to monitor for heart failure and any emboli. Assess your heart sounds every 4 hours, and they have all the same care as you would with a post-cath. Your goal is to mostly focus on those hemodynamic stabilities and recovering from anesthesia. You want your frequent focus to be on neuro, respiratory, and cardiac assessments. So dilated, increased chamber size, and hypertrophic thickened chamber size, restrictive. So when your valves are dilated, it causes increased chamber size, which causes hypertrophic thickened chamber walls. Restrictive has stiffened ventricular walls instead. So on here, we can see here's our normal, here's our dilated, our hypertrophic, and our restrictive. Just as a side note, calcium is a major player in this. So sodium is a major player as an electrolyte involved in cardiomyopathy. Cardiomyopathy leads to heart failure, which develops from fluid overflow. Sodium makes fluid retention worse, so you want to think about how these result in patient symptoms. So kind of thinking about, if I've got fluid overload, how is that going to make my valve problems worse? So now we're going to get into the infectious diseases of the heart. So these can include any of the 3 layers of the heart may be affected by this infectious process. Diseases are named by the layer of the heart that is affected. Diagnosis is usually made by patient symptoms and endocardiogram. And management for all infectious diseases is prevention. IV antibiotics usually are necessary once an infection has developed in the heart. So we've got 2 types of these endocarditis, or types of infectious diseases of the heart. We've got rheumatic endocarditis, which occurs most often in school-age children after group A beta hemolytic streptococcal pharyngitis. So this is why we need to promptly recognize and treat strep throat to prevent this rheumatic fever. Because what happens is we don't fix this, and we'll talk about this in MedSearch 3, but we don't fix the problem, so our body basically develops antibodies against what happened, but we're attacking self instead of attacking what we need to attack. So we didn't treat the strep, and now it's much worse. Infective endocarditis usually develops in people with prosthetic heart valves or structural cardiac deficits. Also occurs in people who are IV drug abusers and in those with deliberating diseases, indwelling catheters, or prolonged IV therapy. So it's very important that we look at our sites. Now with this, if you've got somebody who is an IV drug user, like I said before, usually it's the tricuspid valve that's going to suffer because they're putting it through their vein. That infection goes up into their heart and hits that tricuspid valve. Here we can see that vegetation, like we've got some vegetation here on the mitral valve. And you can see it on this here as well. And bacterial endocarditis, you can see where they've got it all through here. So we also have pericarditis and myocarditis. Pericarditis is that inflammation of the pericardium. There can be many causes. And your potential complications of this are things like your pericardial effusion and your cardiac tamponade. So with that cardiac tamponade, because I've been talking about this a lot, you really want to look for those muffled heart sounds, signs of the circulatory shock, and just making sure that you're aware of it. On assessment, when you listen to this patient, if they've got pericarditis, you will hear that pericardial friction. For your myocarditis, it's an inflammatory process which involves the myocardium. Most common pathogens involved in the myocarditis tend to be viral, and endocarditis, they tend to be bacterial. Complications can include cardiomyopathy and heart failure. So here is our pericardial friction. Like we said, this is associated with pericarditis. So I do have a video on here that just does the sound of what it sounds like, but it's a high-pitched, scratchy heart sound. And it basically occurs as the heart contracts and relaxes within the inflamed pericardial sac. I brought this picture up again because I think it's helpful because it shows different types of like pericardial effusion versus pericardium versus Beck's triad versus acute pericardial tamponade. So with pericardium, that's the buildup of fluid or air. It's considered a medical emergency, can progress to circulatory shock and cardiac arrest. So on here, we've got the sac that's filled with fluid. You'll also hear your muffled heart sounds when we get this cardiac tamponade. Pericardial effusion, pericardial fluid builds up slowly over time, allows pericardium to stretch out to accommodate bigger volumes of fluid without compressing heart. So with them, they will get chest pain, shortness of breath, compression of the near structures. And once again, this is just a picture of your cardiac tamponade. You've got your pericardial sac here, fluid buildup, and as you can see, because we're listening to all this fluid, that's why it's so hard for us to hear the heart sounds, and it's very muffled. Now, if we've got all this fluid, what we can do is what's called a pericardiocentesis. So we're literally just putting a catheter inserted here to remove the fluid. And a lot of times the patients will say, I feel so much better after. So these are some of our clinical manifestations of our infectious diseases of the heart. So things like fever, new heart murmur, friction rub at the left lower sternal border, so for pericarditis. Ozal nodules, Janeway lesions, Ruth spots, and splinter hemorrhages in the nail beds for rheumatic. Cardiomegaly, so that enlargement of the heart failure, tachycardia, splenomegaly, so enlargement of the spleen. Fatigue, dyspnea, syncope, palpitations, and if they've got myocarditis, they might develop that chest pain. Our diagnostic tools are going to be things like blood cultures, echocardiogram, rheumatoid factor, CBCs, ESR, CRP, urinalysis, ECG, cardiac catheterization, MRI, TEE, and CT scan. Prevention, antibiotic prophylactics before certain procedures. So that's why for a lot of procedures, they make sure somebody takes an antibiotic or they'll give IV antibiotics during. Ongoing oral hygiene, because your teeth really do matter. Female patients are advised not to use IUDs. Meticulous care to be taken for patients that are at risk who have catheters. Catheters should be removed as soon as they are no longer needed, and immunizations. And like I said, you want to watch for your sites of infection. So these are some of our sites of infection. We've got a catheter here and we've got an IV line here. On this one, these are all areas that they have started to develop an infection. So on here, we can see that redness. And here we've got that purulent fluid. So we want to watch for these lines because all of that's just going directly into our vasculature. So these are some of our nursing safety, digoxin, sensitivity, and myocarditis. So watch for your toxicities. So looking for things like that yellow vision, nausea, anything that may alert us that they've got DIG toxicity. Pericarditis and friction rub is in the 4th intercostal space, and you're going to hear that scratch. You want to look out for pericardial effusions. Cardiac tamponade, known exam findings to prevent death and treat emergency. So if you all of a sudden notice any signs and symptoms of cardiac tamponade, reporting that. Pulse paradoxes, your jugular vein distension, and increased central venous pressure. All right, so the next one we're talking about is your cardiomyopathy. So it can be subacute or chronic disease of the cardiac muscles. We've got different types: dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy. So findings are really dependent on the structural and functional abnormalities. So like on here, this is our hypertrophic. So you're going to see that enlarged myocardial here. Interventions, so take action. We've got non-surgical, which non-surgical would be things like medications, lifestyle changes, dietary. Surgical, you can do things like your septic myectomy. So the surgeon will actually remove part of the thickened septum that's bulging into the left ventricle. You can do things like surgical implanted devices, so a pacemaker, ICD, heart transplant. Person's diseased heart is replaced with a healthy donor heart. And we're going to talk about this heart transplant. This video here is a very helpful video. It kind of walks through everything with it. I also put this on Momentum. It's only 5 minutes. So post heart cath, some of the things is you want to change your position slowly. Since the vagus nerve is cut, the patient's new heart is not connected to the nervous system, so the patient may not be able to respond to decreases in blood pressure. So it's very important that we tell them stand up slowly, sit down slowly, because their body may not recognize that they're standing up or sitting down. Watching out for immunosuppressive drugs, so watching patient for signs and symptoms of infection. Immediately after, watch for post-cardiac surgery bleeding, post-cardiac surgical arrhythmias, right ventricular failure, and that tamponade. Then we've got our lovely tamponade. Heart does not stretch out fully between contractions. Chambers do not fill properly. Less cardiac output, hypotension. As always, thank you guys.